Good afternoon. My name is Dr. Bill Miller, and I'm going to talk to you tonight about something that's really important to me. I'm probably best described as an old, washed-up internist, but earlier in my life, when I was in practice, there were things that were really very challenging to me and my partners. One of the scenarios that was very frustrating was being called to the emergency room, usually in the middle of the night, with one of our patients who had had a catastrophic medical event and wasn't doing well. The family would be nearby in the emergency room, and I would turn to them and say, "What would your mom like for us to do?" At which time I usually got a deer in the headlights look, and they were forced to make a snap decision based on guilt. So what I'm hoping here with this talk is to give you to think about what it is you want your family to say to me when that time comes. So let's go ahead and get started here. So it really, it may not seem time to make a decision, but it is that you really need to think about your quality of life and what you want. And this is an individual decision that you get to make, and it is your decision, but you've got to get other people to accept what you've chosen and be able to achieve that end. So the real thing is on end of life issues is what quality do you want or do you expect? And where do you draw the line in terms of this is not what I want? So things we're going to talk about this morning or this afternoon are expectations of the quality of life, looking at personal values, looking at things like independence, which is really very important for most of us in terms of living, personal care, daily activities, recreational activities here in Sunriver. And with time, all of us have noticed that there are limitations. They can be cognitive, they can be with ambulation, and they can be cardiac or pulmonary, orthopedic, neurologic. Lots of things can happen, and that really creates an impairment. And then you need to decide, again, how important are those impairments and what can you live with? So in terms of quality of life, some people say, and they're entitled to that opinion, is they are willing to prolong life by any means possible. And they consider that quality of life is something that they want, and even if it's limited, they still want to be alive. Another issue is whether or not you're in pain or misery. And that's where the medical profession comes in, that there are things that we can do, things that we can't do. People who have end of life metastatic cancer often have a lot of pain, they have a lot of suffering, and it's not only just the individual that's suffering, it's the family that's suffering as well. That do you really want your family to have to put up with a period of time when you're very incapacitated, very miserable, and is that really something that you want them to experience? So what you need to do, and we'll work on this a little bit later on, is a quality of life that's consistent with your values. And you get to pick your values. This is not your family values. This is what you want. And one of the things that people try to avoid is being a burden to their family. That the burden can be someone that requires a great deal of care. It can be someone who is in a care facility that is needing a lot of help and getting to the next one, needing a lot of money. That the cost of a nursing home is substantial, $5,000–6,000 a month. And some people certainly live several years at a nursing home before they pass away. Now, if you've got long-term health insurance, that's a huge assist. But if you don't, then that's that money that's being taken from your assets. As someone once pointed out to me, that in a family, one spouse owns half the assets and the other spouse really is entitled to the other half of the assets. So if you use up all the assets, that creates a real problem after you're gone. And then obviously religious beliefs are important, that Everybody's entitled to their beliefs. There are some religions that feel strongly about sustaining life, regardless of the quality of it. But again, that's something that you need to decide and be able to share that. So, what is quality of life? For me, it means being able to make care of my own decisions every day. What I want to do, where I want to go. It means things like being able to take care of myself personally, to dress myself, to fix my own meals, to eat and clean up. And that's very important. That I want to be conscious and I want to be aware of my surroundings. And that really varies. Some people get a little fuzzy as they get older. But once you reach a certain point in time where you don't recognize your family, don't recognize your spouse, then you're really not aware of your surroundings. And that creates a burden for your care and also for the people around you. You need to be able to communicate with family and friends. If you've either had a stroke where you can't speak or you're mentally not capable of carrying on a conversation, that creates a great deal of difficulty in terms of establishing any kind of relationship with the people that you've known or your family. And the next one is being comfortable and pain-free. All of us, certainly as we get older, are no longer pain-free, but at the same time, we ought to be able to control that. There's requires an effort in terms of working with your provider to make sure that you are reasonably comfortable. This is sort of contentious more recently where people are concerned about overuse of narcotics, but at the same time, underuse of narcotics and people suffering is, I don't think, appropriate either. And then lastly, people want to be able to get out and about. It makes one thing to be housebound or bedbound as opposed to being out where you can walk with a wheelchair or a walker or a cane and get to where you want to go. If you're housebound, that means everything has to be brought to you. And that is, again, a burden on yourself and it's a burden on everybody else. So you need to think about what it is that you want, and then you need to look at how the medical profession can help you. The profession over the last years has really become very good at sustaining life, perhaps even a little too good. And there are things like cardiac resuscitation, which we'll talk about in a little bit. But if your heart were to stop, would you want it to be started again? If you've got end-stage pancreatic cancer, the answer to that is pretty resounding no, I think. However, if all of a sudden a little piece of plaque comes off your left anterior descending coronary artery and your heart fibrillates, with a little luck, there's somebody around with a defibrillator and shock you back into rhythm again. A trip to the cath lab at St. Charles Hospital, and the next morning you're practically good as new. So the question becomes, if your heart does stop, under what circumstances would you want to start it again, or do you want to call it good? Another issue is ventilators, which obviously have been a big issue since COVID-19. A ventilator is something that is sort of perceived as a short-term, self-limited treatment. That's not always the case. And the question is, if you reach a stage where you can't come off the ventilator, where you can't breathe on your own successfully, what is it that you want to do? The same thing is with pain management, that you would expect some reasonable degree of management consistent with your needs. And hopefully you'll find a provider and family members that are supportive of that. And then towards the end of the line is comfort care. And I think most people know about hospice, which has been around for probably 20 years. And hospice is an end-of-life assistance that is paid for by Medicare and provides a lot of care that's really important both to the individual and to their family. If you're in a nursing home and you fall down and hit your head, they're by law required to send you to the emergency room. If you're on hospice, they'll have a nurse come out and check you out, and you save that trip to the emergency room. And the same thing at home. If you have someone that's living at home that is on hospice and things go badly or there's a change, rather than a trip to the urgent care or to the emergency room, there are nurses that will come out, check things out, adjust your medications, and save both you and your family a lot of grief in terms of going to a care facility that's really not necessary. Another option, which is less well known, is palliative care. And this is for people where in hospice, there's no longer any therapy being considered. It's simply maintaining quality of life until you die. In palliative care, it's sort of an assistance in maintaining quality of life and comfort while you're still being treated, so that somebody who is getting chemotherapy or radiation, or who is recovering from some sort of medical event, this allows them to have care that is also geared just for what they need. The first word that I'm going to say about feeding tubes is don't. That there are several types of feeding. If someone can't take in enough calories and vitamins and minerals, there are several ways to treat that. On a short-term basis, while you're in the hospital, they can do that by vein and give you, for a period of time, all of the calories, all of the essentials that you need. But this requires being in the hospital. If you move to another facility, there are other options. Seldom used is a small tube that is placed through the nose into the stomach and will drip in liquid and nutrition. The problem with this is that you're fairly immobile and it takes a long period of time to administer what you need. The newer thing is a feeding tube that is placed through the stomach, through the abdominal wall into your stomach. And this is done with an outpatient procedure, fairly straightforward and quickly done, and really allows you to be fed by someone who is not necessarily trained. There are commercial products that are available, but you can actually just take what everybody else had for dinner, put it in a blender, and then with a syringe squirt it into your stomach. And that's actually very efficient. You can give liquids, you don't have to chew, it all tastes the same, but you can maintain an appropriate degree of nutrition. The problem with this is not putting it in, it's taking it out. Once someone has a feeding tube in, it is incredibly difficult for the family or the spouse to say, no, you can go ahead and take it out, we're gonna quit feeding him. So that decision to make and put a feeding tube in, which is easy to do, and I think most physicians are kind of reluctant to do it, but they will if the family insists, is not a good choice for a long term. If you've got a situation where it's going to get better, then that's reasonable. For something that's going to be lingering, or someone in a chronic vegetative state, you can actually keep these people alive for years if that's what you want. But hopefully you don't want that and your family doesn't want that. In 1994, the state of Oregon approved Death with Dignity Act. This allows someone under very limited circumstances, less than 6 months to live, reasonably capable with cognition, and being approved by both a provider and a specialist, to be able to be given a lethal supply of usually Seconal, which is a sleeping pill. And you can administer, yet the patient has to administer these themselves. They can't be administered by the family. And usually with a fair amount of success, people die within the next 24 hours. Last year, there were less than 200 people that did this in Oregon. So the reason that it's popular is not because of the death, but rather because of the control. That people, when they're critically or terminally ill, feel that they have lost all control about what they want. And this is an opportunity for them to regain some of that control. And I think it's really something that not many people want, but should be willing to consider if they so choose. It's difficult to find a doctor that will support this because there's a lot of bad press about people that do this, but it's still a legal option. And I think for patients who are in the situation where they are going to die in a relatively short period of time, I think it's of value. And I think they're entitled to that if they wish. The other is suicide, which I don't recommend. That is often successful. People do it in desperation. The effect, although the suicide may be successful, the effect on the family is devastating and long lasting. So that's really something that I think should be avoided. And you should talk to your family, you should talk to your provider and look at where you are, what your feelings are, and how you want to deal with that. The last thing I would mention is two things. One, organ donation, and secondly, I have failed spell check. That although your organs may be well used, that's a decision that maybe somebody else should make. It's reasonable to offer a kidney, a liver, corneas, skin, other things for somebody that really will be of great value to them, and in some cases, life-saving. This is a pamphlet that has been put out by the Oregon Health Decisions, and you can get one of these from your provider. It includes the same sort of topics that I'm talking about, and gives you some forms in there that you can fill out, and really is a great way to start a discussion. The real question I have is, why are all these people smiling? I just have a feeling the daughters have done something with their mother that we don't want to know about. This is a PULSE form, and everybody should have one. PULSE stands for Physician Orders for Life-Sustaining Treatment. And the first one is resuscitate or not resuscitate. And again, it's a yes/no question. But again, like I talked about earlier, there are times when it might be no, and there are times when it might be yes. So my proposal would be to keep it a yes until it's clear that there's really no reason to continue life. The second question is medical interventions, and it's comfort measures, limited interventions, and full treatment. But again, that's not just 3 boxes. That's a continuum of options, which may include IV fluids, it may include antibiotics, it may include oxygen, it may include feeding. So that these are the sort of things that you need to be decided. And I don't think that you can really ask someone to make a decision based upon 3 boxes, one of 3 boxes being checked. The next one is artificial administration of nutrition. I've kind of talked about that. And again, the answers are yes, no, and maybe. And then the last one is E. This is a form that has to be signed. It has to be signed by a physician, a nurse practitioner, or a physician's assistant to make it legal and binding, so that your dentist and your chiropractor can't sign it. But this should really be something that you should talk with your main provider and be comfortable with how it would be implemented should something happen. This is the beginnings of an advance directive. And, this is not my favorite form, but it asks for several questions. And the first one is, if you're close to death, what do you want? Tube feeding only as my physician recommends, or I do not want tube feeding. And again, it's sort of yes, no, or maybe. And it's a decision that someone would struggle making if they were really in reasonable health for a situation where they don't know what's going to happen. This is some more of the same thing, asking if you have suffering, what do you want? And it says extraordinary suffering. I'm not sure what extraordinary means. That's in the eyes of the individual. And again, this is something that should be completed, but at the same time, I think the best way to deal with this is talk to the people that are going to be administering this and have them understand what your wishes are and make a decision. Here we go. Okay, so who do you talk to? You've listened to this thing long enough, and you decide that you're going to talk to somebody and you're going to think about it. So the first person you should talk to is your family, your spouse, your children, and tell them that you're thinking about this and this is what you would like done or not done. In addition, your medical provider needs to have that information so they can manage it. And there are forms that you can fill out that I've shown you that sort of get a start to what you will be receiving or not receiving. The other question is, do you have a split group where some people feel one way about your demise and some people do not? This is where you may need to get an attorney involved to make sure that your wishes are supported. If your family's divided and there's one contingent that is willing to accept your wishes and another contingent that does not, that can create a problem. When I was in practice, we had a patient who was terminally ill and ready to pass on. The son from New Jersey, who had not been out in 20 years, showed up and wanted everything done and was forceful enough to achieve that end. If you think that there's a risk for this, then you need to make sure that you're protected when that time comes. Another way that I think is concerning is when you select a representative, which is usually a spouse or a family, are they going to have the moral wherewithal to accept your wishes? And if it comes to things like turning off respirators, turning off feeding tubes, are they going to be comfortable or at least willing to do that? Because if they won't, then that creates a problem where the person that you've turned to represent you is really not representing your wishes. One thing that I have not seen done, but I think has merit, and I'll have to admit I haven't done this myself, is to have a short narrative of what your desires are. Now, we're not talking a booklet here. We're talking maybe a few paragraphs that describe your feelings about what you'd want done and who you want to take care of it. So I think that this is an important part of making sure that your wishes are followed. So as you might imagine, there are forms. The first one is a will. Somebody always tells you you need to make out a will. Actually, you don't, because if you don't have a will, then the state of Oregon has a will. It's the same one for everybody without a will. So it's probably a better idea to have your own. You need to have power of attorney because your spouse or family, if you are incapacitated but still alive, need that power to pay the bills and do things. The POLST form we've talked about, the advance directive we've talked about, and those are things that everybody needs to complete. And you just never know when you're going to use them. One thing that we did in my practice was we got tired of going down and having the scenario that I've described at the beginning. And so we sent everybody over the age of 65 a POLST form in the mail and with instructions on how to fill it out, and told them to bring it back and we'd talk about it and sign it and it would be done. That really was very well received. Not only did we get some back, but also it's initiated a conversation with people about what they wanted. And I think that was of great value. We implied but didn't actually follow the suggestion that if you didn't fill it out, the office would fill it out as they saw fit. So let's move on to some examples. This is, the first one is somebody that's really at the end of the line, that they're young, but they've got metastatic carcinoma. They've had all the usual treatment. There's one more drug that has about a 10% chance of making a difference and a 90% chance of making you sick. So this is really where you look at quality of life. And would you rather be more comfortable in your remaining time and be able to interact with your friends and family, or sicker than all get out from the medication? The second one is a 75-year-old male who had a bad stroke and is left with paralysis on one side and great difficulties with any kind of speech. As a result, they can't live independently. They're going to be in a nursing home, and that because of the damage to the brain, it's really not going to get any better. This is a challenge where sometimes right after a stroke, they're vulnerable, and you can choose not to continue supportive care or not. But if you do, and then they reach a stable situation, this is what you're left with. And it's a real problem where You're now going to be in a care facility, which you really probably didn't want to be in. You're going to run up a big tab on your family's assets. And how do you deal with this? And it's not easy. One thing to consider would be to stop feeding. That if you choose not to accept water or food, which is your right, they're not going to force feed you, and that will allow people to pass on. This is something that really requires the agreement of the individual, and usually in advance, the family, and also the care facility. So this is a very difficult situation, and it's really an ugly one that you want to try to avoid if possible. The last one I've changed, and instead of a 60-year-old female who slipped on ice and fractured her hip, this is a 60-year-old female who went to a family reunion and didn't wear a mask, and she has COVID now, and she's starting to struggle with breathing. She has smoked before, which makes you more prone to get in trouble. And she's reached the point where she's getting tired breathing and she's not going to be able to continue it. And the question is, do you want to be intubated and transferred to the ICU? And if you do that, how long do you want to be on the respirator? Is that something that you'll continue indefinitely? Or do you want to say, if I'm not better in 72 hours, call it good? So I think these are the kind of questions that are unexpected, but the family is going to have to make that decision, and they need to be able to have your input prior to all of this happening. So now you've been told what to do. The next step is to go out and do it. So I hope that this has been of value and let you think about what it is you want to do, and then not only think about it, but make a decision and share it with your family. So I think we'll pause here. I don't know if anybody has any questions, but hopefully this has been of value, and you've been able to think that this is something that you might need to think some more about.
Yeah, thank you.